Well, good evening, everyone, and welcome to the fourth installment of our STI and BBB refresher series. My name is Jamie, and I am joined by Dr. Parker, who I will introduce in a second. But before we jump in, I just want to do an acknowledgement country and acknowledge and pay respect to the traditional owners and elders of the land that we are meeting on today, recognizing their diversity and the significant importance of their cultural heritage, values, beliefs, and self-determination in contributing to the positive health and well-being of the whole community. So just a disclaimer, this webinar tonight will be recorded. So for the time being, we do have mics and cameras off, but if you do have any questions, feel free to pop them in the chat because we will have some time later in the webinar for questions. So as mentioned before, I am joined by Dr. Parker, who is our speaker this evening, and she is a public health physician at Boorloo Public Health Unit with a special interest in Hep C. And in her spare time, Dr. Parker likes to do DIY home repairs that she says she's not qualified for, but I doubt that. And she likes to travel and she enjoys going to music gigs. So thank you so much for joining us, Dr. Parker. I will hand straight over to you.
Well, thank you for having me. All right. So today I'm going to speak somewhat briefly about hepatitis C testing and interpretation. So we'll cover off potential indications for Hep C testing, how to offer testing, the different types of tests, how to action the results, and quickly revisit where we're up to with hepatitis C elimination. So firstly, the indications for Hep C testing. As you know, Hep C is a blood-borne virus, and the primary risk factor for acquiring Hep C in Australia is injecting drug use, and particularly shared injecting equipment. It's estimated that around 90% of Hep C infections in Australia are acquired this way. A history of incarceration is also very important. People who inject drugs are overrepresented in these settings, and there's also an absence of the usual harm reduction measures that are present in the broader community, for example, the needle and syringe programs and opiate agonist therapy options. But that said, the indications for testing are broad, as you can see on the screen here. So Hep C is part of a standard liver screen, it's part of the PrEP initiation screen, and of course, medical causes, medical care has been at fault for many historic Hep C infections as well. So we do need to keep that in mind. We mentioned here migrants from high prevalence regions, with Egypt being at the top of the list. There's a classic bit of history there where in the 1950s to 80s there was a mass community-wide intravenous treatment program for schistosomiasis, where parts of needles were reused or suboptimally sanitized, and that caused widespread transmission in the community and the high volumes of liver complications, and their cause were only detected decades later. Now, on the other side, Egypt is a leader in hepatitis C elimination. So I guess the message is, where possible, it's really important to destigmatize Hep C testing and acknowledge a diverse array of possible causes and sources, and make it a more routine occurrence in care. So how might testing be offered with that normalization in mind? It can help to use a hook that sort of links in the testing to other aspects of care, or makes it sound like a more routine thing. So the examples I have up here, we're offering routine STI and BBB testing as part of our general assessments, or it looks like we haven't done a Hep C test for you in the last 12 months. Would you be happy if we did one with your bloods today? Or relating it back to whatever the consult is about. Sounds like all that fun in Bali warrants a few tests, for example. Asham suggests that informed consent for Hep C testing could and should include why Hep C testing is a good idea, and that curative treatments exist in the event of a positive result. So the standard testing approach for Hep C is up on the screen. So all tests are via blood. If your patient has no known history of Hep C, or you don't know, then testing starts with serology, and that's looking for the antibody to hepatitis C virus. So if that's negative, then your patient has never had a Hep C infection. If it's positive, then they have had a Hep C infection, but you don't know if that is a past or present infection, the antibody will remain positive for life, even if the infection has been cleared. So to clarify that, you have to do a HCV RNA test. So they can be a qualitative test, which gives you a detected, not detected binary result, or it can be a viral load, which is a quantitative result. Both are looking at the RNA genetic material, so either will do. If the RNA is negative, it means that the infection has resolved sometime in the past, either from treatment or from having spontaneously cleared. We know that in adults, around 28% of acute Hep C infections will spontaneously clear in the first 6 months without any intervention, and the remainder will go on to become chronic infections needing treatment. However, if the RNA is positive, you've identified an active viremic hepatitis C infection. One important thing to note is that many Hep C patients fall through the gaps between having a positive antibody screen and then going on to get their RNA test done. And in many cases, it can be a huge challenge to get patients back in for a second round of testing. Reflex testing is not currently automatic for most labs in Australia, and the RNA test has to be specifically requested. So for this reason, ASHM suggests requesting Hep C serology plus viral load if positive on the path form so that the lab can proceed to do the RNA test on the same blood draw. Here we have a schematic of a hypothetical patient showing viral load and antibody test results over time. So I suppose unlike Hep B infection, getting Hep C once does not confer any kind of short or long-term immunity, and it's quite possible to be reinfected multiple times. So this plot shows a 10-year period. Firstly, the antibody is there in the darker line. So the antibody will become positive after that first infection after a window period of about 30 to 60 days, and then it will remain elevated for life. The viral load, on the other hand, is detectable within about 7 days of acquisition, so it actually goes up sooner. Then you can see this hypothetical patient has their first infection for about 2 years, then gets treated and their viral load returns back down to 0. Then they subsequently are reinfected again. Their viral load shoots back up. And you can see how retesting the antibody here would not offer you any more information if you already knew about that first infection. So it's important to rescreen with an RNA test if you are testing for a reinfection. In that case, the second time round, the infection spontaneously clears and viral load falls to 0 once more. And then you can see about 3.5 years later, they get another infection, and you would need another RNA test to detect that reinfection. So a quick note about point-of-care tests for Hep C. They exist, and they are in limited use in Western Australia currently. At least 2 clinics have them up and running to my knowledge. There are most likely more than that. So you can see in this table, there are tests for both antibody and RNA, and both. So all of them are blood-based tests, usually via finger prick, and these are then put in a lateral flow test assay or a gene expert machine. And there's also the potential for dried blood spot in this space as well. So these can be used for diagnostic and treatment decisions if the test is registered with the Therapeutic Goods Administration and it's administered by a trained person in line with pathology accreditation standards, which usually implies quite rigorous quality control programs. And so to meet these criteria, the programs are usually supported by research institutions like Kirby. And outside of those approved settings, any positive results need to be confirmed with standard Hep C lab-based testing. And as you can see with the approvals here, it is quite possible to have your antibody and the RNA test both done point of care and potentially then going on to treatment decisions same day. So how should the results be actioned? So for a negative antibody screen, you should consider what the indication was for the testing. So if there was a recent exposure, perhaps repeat the test after a 3-month window. If there are ongoing risk factors for transmission, plan to repeat that screening annually. And then depending on the patient, it might also be prudent to discuss potential modes of transmission and risk reduction options for them. An antibody positive result alone is an incomplete diagnosis, and that should prompt a request for an RNA test. An antibody positive result with negative RNA means a resolved infection. So once again, it might prompt that annual rescreen if there's ongoing risk and discussion of risk reduction. And then the antibody positive result with positive RNA is where we need to progress a workup for treatment. And that pre-treatment assessment has a few essential steps. The first thing we need to know is the patient's measure of cirrhosis. So there are a few ways to do that. It can be via an APRI score, which is a simple calculation using the AST, the part of liver function test, and the platelet count. And there are online calculators for this. So that has the benefit of being quite quick and usually using markers that you already have at hand from existing testing. Alternatively, or in addition, you can order a fibroscan or another ultrasound-based elastography scan. You also need to know if there's any past history of Hep C treatment, as this may change the preferred treatment option. You need to know if the patient is pregnant or breastfeeding, as these are contraindications to treatment. And you also need to know if there are any drug interactions that need to be managed. And again, there's an online helpful tool for that. And then in an ideal world, the pre-treatment assessment also has a few extra steps and tests, and you can see those up on the screen, although those aren't necessarily barriers to commencing Hep C treatment. Treatment has come a long way since direct-acting antivirals were introduced in 2016. The two main options are Mavorette, which is 3 tablets daily for 8 weeks, and Epclusa, which is 1 tablet daily for 12 weeks. Both are first line, and there's no kind of preference between them. The treatments are both heavily PBS subsidised from a raw cost of about $36,000 per course, down to a patient cost of about $95 for the entire 2 to 3 month course, which is reduced again if the patient has any concessions. In most cases, the treatments can be prescribed in primary care, and there's no specific training or qualification required. The treatments are well tolerated and they are highly effective. An authority script is required. So at the time of seeking approval, you need to provide the patient's cirrhotic status as well as details of any previous Hep C treatments. Then you also have to document in the patient's medical record any evidence of chronic infection as well as the genotype if known. Now this evidence of chronic infection used to be a bit of a hiccup. So the PBS wanted clinicians to demonstrate that the patient had repeated RNA positivity before they would give authorization. And nowadays, the general trend is that if you don't have specific evidence of recent infection, ASHM recommend that any RNA detection be considered for treatment if there are ongoing risk factors for Hep C transmission. So their line of thinking is don't wait around for 6 months to see if the infection will clear, because in most cases it won't. And for many Hep C patients, the risk of disengagement is too high. So where can you get support? So for prescribing, if you're uncertain, the tertiary hepatology services will take phone calls seeking advice. There's also the WA Hep B hub. While focusing on Hep B, they are also happy to take Hep C queries. So the hub is staffed by a nurse practitioner in hepatology who will respond within 2 days. So these are good for more experienced prescribers, perhaps with simple questions. But there are also the next 2 options up here which support remote prescribing. So potentially better for less familiar prescribers who need a little bit more support with their decisions. So with these options, you can enter in a proposed treatment plan and the specialist will give feedback. So the WA health form can be faxed to a specialist of your choosing, and the REACH-C form is submitted online and reviewed by an Australian specialist. Not necessarily in WA, but the turnaround time is fairly reasonable. Some patients will need specialist referral. So the indications are listed there at the bottom of the screen, with the most common one being demonstrated cirrhosis. So in the public system, referrals are all via CRS. All patients can be referred privately. It's important to note that public hospital clinic waiting times are becoming quite long, in the order of 12 to 18 months sometimes. So they do ask that we try and stick to the referral criteria and make use of the remote support options where possible. And then if you're having trouble recalling your patient or they have fallen through the gaps, so to speak, it's worth seeing if your public health unit can help. And then in some circumstances with patient consent, you may be able to refer them to other services that have different models of care that may be more suitable. And the couple of examples I have here are peer-based harm reduction, which offer a mobile service with point-of-care testing and same-day scripts for people who inject drugs. And then the Dean Clinic is kind of a one-stop shop for hepatitis, run by Hepatitis WA. And so again, with the point of care tests there, it can reduce appointment burden for patients if that is a concern. All right, and then briefly, elimination, where are we up to? So Hep C is still causing about 20 to 30% of cirrhosis and hepatocellular carcinoma in Australia and requiring dozens of liver transplants each year. With deep inequities in the population groups affected. Australia has endorsed the World Health Organization's 2030 elimination targets, and this has become like a possible reality with the new effective treatment since 2016. So how's it going? Back at the beginning of 2016, there were more than 162,000 people thought to be living with Hep C in Australia, and in 2024 that was down to an estimated 68,900 people. In 2016, about 72% of cases were getting that RNA test to confirm active infection. That's up to about 76%. And beginning of 2016, only just over 4,000 people had been treated with DAAs. And at the end of 2024, we had nearly 106,000 courses of treatment prescribed. And that equated to about 63% of those initial people in 2016 with Hep C having now been treated. So Australia is not yet on track to achieve elimination by 2030, but there's certainly a lot of momentum and new initiatives coming up all the time. And one by one, every cured case contributes to reducing onward transmission through treatment as prevention. So the key takeaways I want to leave you with, indications for Hep C testing are broad, and we should try to normalise and destigmatise bloodborne virus testing. Attrition between serology and RNA testing is high, and writing Hep C serology plus viral load if positive on the path form can help to address this. When screening for reinfections, skip the Hep C serology, go straight to RNA testing. Point of care tests exist and they are currently being used in WA, so you may encounter results from these systems. Consider treatment for all RNA positive patients. Most patients can be treated in the primary care setting and help is available to support that. And finally, every treated patient contributes to our elimination goals for Hep C. And I do think that Hep C might be our next big win in public health. We're getting there. All right, that's it from me. Thank you very much.
Thank you, Dr. Parker. That was extremely insightful, and I think it was a really great way to also bring an end to our STI and BBB refresher series. So thank you. We don't have any questions, so that brings us to the end of our webinar this evening. We thank you for joining us, and if you do have any feedback where you would like to see any topics from us in the future, feel free to also scan the QR code and fill out the survey just to let us know. And on behalf of myself and Dr. Parker, we wish you a lovely evening. Good night.
Thank you.